Welcome back to the deep dive. Our mission here is to take the densest, most critical material, the stuff you absolutely have to know, and really distill it down into memorable, applicable knowledge.
Exactly. We're trying to give you the anchors you need to navigate all this complexity without sinking into information overload.
And today, we are undertaking a truly crucial deep dive, maternal medicine. We're pulling our core insights from Chapter 32 of Davidson's.
It's a field that is just inherently complex. I mean, pregnancy isn't a sickness, obviously, but it's a massive physiological event.
Right, you're managing two lives.
Two lives, and the maternal physiology just radically shifts. It alters virtually every single baseline reading you've learned since, first-year anatomy.
That's the real challenge, isn't it? If you're a first or second-year medical student, this chapter can feel like a list of exceptions to all the rules you just mastered.
It can. So we need some core structures, some guiding principles, the anchors. That's what's going to let you manage this constant state of flux.
So where do we start?
We have to start with the context, which really defines the life or death stakes involved here. Pregnancy is the ultimate physiological stress test.
The ultimate stress test.
And the confidential inquiry into maternal deaths. It provides this sobering statistic that just reorients our focus entirely.
Go on.
It shows that approximately 2/3 of maternal deaths are due to pre-existing medical conditions.
Wait, 2/3? So they're not from issues arising purely from labor or delivery?
Exactly. Not from classic obstetric causes. They're from underlying conditions being stressed to the breaking point.
Wow, that's a staggering figure. It means the critical skill isn't just knowing how to manage the labor room.
No, not at all. It's knowing how to detect, manage, and anticipate how pregnancy is going to stress a woman's underlying cardiac system, or her renal system, or her immune system.
Okay, so what are the big killers then?
The top 3 causes cited in the source material are, number 1, cardiac disease. That accounts for 23%.
Nearly a quarter.
Then venous thromboembolism, or VTE, at 16%. And third, neurological disorders, contributing 13%.
So our mission for this deep dive is really to master this physiological new normal so we can spot these high-stakes, life-threatening pathologies early.
That's the mission.
So let's introduce our central pedagogical anchor for today. We need something to help us conceptualize all this rapid, constant change.
Right. Let's call it the maternal highway of adaptation.
The maternal highway. I like it.
Imagine normal pregnancy is like operating a meticulously engineered high-performance vehicle, a race car.
Okay.
But the mechanics have tuned it for maximum output. So the dashboard readings, your lab values, your vital signs are now constantly running in this turbocharged state.
So our job is to memorize the expected readings for this high-output machine.
So you can recognize when a true engine warning light, a genuine pathology, flashes on that dashboard.
And that journey on the highway starts before the engine is even turned on, right? The preconception principle.
It has to. Planning is just non-negotiable for patients with pre-existing conditions. The primary principle is rigorous safety.
Meaning what, specifically?
It means ensuring that any drugs known to be fetotoxic, toxic to the fetus, or highly teratogenic, are stopped well before conception, and that high-risk patients are brought under close, multidisciplinary surveillance.
And this isn't just a suggestion. This is a directive tied to preventing severe fetal harm. We need to be able to just recite these drugs.
You do. The non-negotiable list includes immune suppressants, like methotrexate, leflunomide, and mycophenolate. And critically, the anti-epileptic drug sodium valproate.
We'll come back to valproate, I'm sure.
We will. You have to ensure patients are switched to safer alternatives before the pregnancy even begins. That's rule number 1.
Okay, let's unpack the dashboard readings for this maternal highway. Before we can even talk about warning signs, we have to establish what this physiological new normal looks like across the major systems.
Absolutely. We'll start with the cardiovascular system. It undergoes the most radical changes. We can call this our hyperdynamic state anchor.
Hyperdynamic.
And this isn't just a slight adjustment. The circulatory system has to increase its total volume by up to 40%.
40%. That's huge.
It's massive. It's to supply the placental bed and the fetus. And to handle this, the heart increases its rate and its stroke volume dramatically, leading to a huge increase in cardiac output.
So the heart is essentially pumping a much larger volume of blood much faster. What does that actually translate to when we're checking vital signs?
Okay, so your clinical anchors here are very clear. First, the heart rate. It typically increases by 10 to 20 beats per minute. So a bit of tachycardia is the new normal.
Right. A heart rate of 95 is expected.
Exactly. Second, And this is the counterintuitive part that trips up most learners. Despite this huge volume increase and high cardiac output, the diastolic blood pressure actually falls.
It falls.
It falls. It reaches its nadir, its lowest point, in the second and early third trimesters.
Wait, hold on. If the heart is working so much harder and the volume is up by 40%, why isn't the pressure going up? That feels like it contradicts basic physics.
It feels like it, but that's the adaptation at work. The body is using massive peripheral vasodilation.
The blood vessels are widening.
All throughout the body. It's primarily mediated by progesterone and other placental factors. This systemic vasodilation causes a profound reduction in what we call systemic vascular resistance, or SVR.
And blood pressure is cardiac output times SVR.
You've got it. So the drop in SVR is so significant that it actually overrides the increase in cardiac output. And the result is that hallmark fall in diastolic pressure. A stable, or God forbid, a rising DBP in the second trimester can actually be a very early sign of trouble.
So that makes a standard non-pregnant normal BP reading of, say, 120/80 look kind of dangerous for a woman in her second trimester.
It does.
That 80 millimilli Hg diastolic pressure is actually too high for her expected new normal.
Precisely. If a pregnant patient maintains a diastolic pressure that we would call normal for a non-pregnant adult, it suggests they've failed to achieve that necessary vasodilation, and that puts them at a very high risk for developing pathological hypertension, like preeclampsia.
And what about auscultation? If we listen to the heart with a stethoscope, what changes should we expect to hear?
Well, because of that high flow state, you should expect to hear physiological murmurs. The critical auscultation rule is this: an ejection systolic murmur.
The sound of blood rushing out.
Right. Caused by increased volume flowing across the aortic and pulmonary valves. That may be a totally normal part of pregnancy. But, and this is the absolute anchor, a diastolic murmur is always pathological.
Always.
Always. It indicates underlying valvular disease, usually mitral or aortic regurgitation, or much more dangerously, stenosis. It demands immediate referral and investigation. You can ignore the systolic flow murmur, but you can never, ever ignore a diastolic one.
Even the ECG changes are they're purely mechanical, right? It can look like pathology, but it's just plumbing.
That's a perfect way to put it. It's just plumbing. The growing uterus pushes the diaphragm up, and that mechanically shifts the heart's position in the chest.
So the EKG looks different.
It can look very different, and it might normally raise an alarm. We can see up to 15 degrees of left axis deviation, T-wave inversion in leads 3 and AVF, and sometimes even mild ST depression. Understanding this mechanical shift saves you from chasing down a sick-looking ECG that is simply the anatomy adapting to the pregnancy.
Okay, so let's move on to fluid management and filtration, the renal and hematological systems. For the renal system, you used a metaphor, the overflow pipe. How does that work in practice?
The overflow pipe is just working at max capacity. It has to because of that 40% volume increase and the hyperdynamic circulation. So renal perfusion, the blood flow to the kidneys, increases by a massive 80% early on.
80%.
Consequently, the glomerular filtration rate, the GFR, the rate at which the kidney cleans the blood, it increases dramatically, by a full 50% by the second trimester.
So what's the clinical consequence of all that hyperfiltration?
The crucial physiological finding is a fall in serum urea and serum creatinine.
They go down.
They go down. The anchor here is that low creatinine and low urea are the new expected normal. For a non-pregnant adult, a creatinine might be, say, 90 moles. For a pregnant patient, we expect it to drop down to the range of 40 to 70 moles, all because of that hyperfiltration.
That means if I see a creatinine reading of 90, which I would just sign off as completely normal on a general ward, I have to flag it as potential pathology in a pregnant woman.
You must. That reading of 90 mmol indicates that her kidney is failing to achieve the necessary 50% increase in GFR. It signifies an acute kidney injury, an AKI in this context. It is a perfect example of how the normal reading for the maternal highway is actually 5-alarm warning light.
And this hyperfiltration explains the common issue of seeing glucose in the urine, too.
It does. The massive increase in the filtered load of glucose often just overwhelms the kidney's capacity for reabsorption. This means mild glycosuria, a little glucose in the urine, is common, even in women who are not diabetic.
And anatomically.
Anatomically, all this increased pressure and volume leads to what we call physiological hydronephrosis. It's a slight dilation of the ureters and the renal pelvis, which is often more prominent on the left side, usually due to compression from the sigmoid colon.
Okay, moving to the blood itself, the hematological system, we have two contradictory things happening here. hemodilution, what you called physiological anemia, and then this terrifying increase in clotting risk, hypercoagulability.
That's right. The physiological anemia anchor is pretty straightforward. Hemoglobin concentration falls by about 20%.
Why?
Because the plasma volume, the liquid part of the blood, increases much more rapidly and significantly, up to 40%, than the red cell mass does. So the net result is hemodilution. The blood is thinner, which paradoxically reduces overall blood viscosity and improves circulation a little.
But the danger lies in the clotting factors.
Absolutely.
Yeah.
At the same time, the body is cranking up the production of multiple clotting factors. We're talking factor 8X, and fibrinogen. And it's also reducing the activity of natural anticoagulants.
So it's a perfect storm for clots.
It is. The source highlights that this creates a profound inherent hypercoagulable state. This dramatic elevation in VTE risk is why it is the second leading cause of maternal death. The pregnant state is constantly primed for clot formation.
Now, let's tackle the hormonal chaos of the endocrine system, specifically the thyroid, which gets thrown off by an imposter hormone.
The imposter is the HCG mimic. In the first trimester, the trophoblast cells, which go on to form the placenta, produce human chorionic gonadotrophin, or HCG.
The pregnancy test hormone?
That's the one. And its molecular structure is fascinating because it's structurally homologous to TSH, thyroid-stimulating hormone.
So it's a TSH imposter that actually tricks the thyroid.
Precisely. It stimulates the thyroid gland directly. That causes an increase in the production of the active hormones T3 and T4. This results in free T4 levels rising in the first trimester.
And the pituitary gland sees this and backs off.
Exactly. Because of the normal pituitary feedback loop, the raised T3 and T4 then suppress the body's own production of TSH. So TSH levels can fall by almost 50% in early pregnancy.
This sounds like a recipe for impossible lab interpretation.
It is, which leads to our crucial clinical rule for the thyroid axis. Because TSH levels are unreliable and suppressed by this HCG mimicry in the early stages, TSH provides the best, most reliable measure of overall thyroid function only after about 16 weeks gestation.
After 16 weeks.
Right. Once the HCG levels have stabilized or started their normal decline, early TSH values have to be interpreted against much lower pregnancy-specific reference ranges.
And finally, the metabolic stress of glucose metabolism. Tell us more about the why behind gestational diabetes.
Okay, the key physiological feature here is a massive induced maternal insulin resistance. This typically begins in the second half of pregnancy, and the main culprit is a hormone called human placental lactogen, or HPL.
And what is HPL trying to achieve metabolically?
It's a mechanism of metabolic triage. You can think of it that way. The primary effect of HPL is to act as an anti-insulin agent. It makes the mother's cells resistant to her own insulin.
Why would it do that?
Well, this reduces the mother's glucose uptake. And by doing that, it ensures that glucose is preferentially shunted across the placenta to supply the growing fetus, which depends entirely on maternal glucose for its energy. It's a survival mechanism for the baby.
But if that maternal system can't overcome the resistance, she becomes hyperglycemic, and that creates huge problems for the fetus.
Exactly. The moment the mother becomes hyperglycemic, that excess glucose crosses the placenta rapidly. The fetus's pancreas sees all this high glucose and responds by just pouring out insulin.
And fetal insulin is a growth hormone.
A powerful growth hormone. It drives excessive fat deposition and growth, leading directly to increased birth weight macrosomia and a whole host of neonatal complications like hypoglycemia and shoulder dystocia.
Okay, we've established the new normal for the engine on our maternal highway. Let's do a crucial knowledge check, focusing on that really counterintuitive renal anchor. Host check-in question. If you review lab results for a pregnant patient at 28 weeks gestation and their creatinine is 90 millil, what must you consider? Is this normal? And if not, what condition does it signify, and why should you be immediately concerned? I strongly encourage you, if you're not sure, just rewind to the renal segment.
The finding is profoundly abnormal in the context of pregnancy. It is not normal because the physiological expectation is for the GFR to increase by 50% and for the creatinine to fall into that 40-70 molar range. A reading of 90 mol signifies a failure of that adaptation. You must immediately suspect the onset of acute kidney injury, AKI, often secondary to preeclampsia or some other pathological process. This is a 5-alarm warning light on the dashboard.
So the lesson is clear. In pregnancy, the normal reading is often the warning sign.
That's it. So key takeaway 1. In pregnancy, the physiological state is fundamentally hyperdynamic and hemodiluted. Low urea and creatinine are the new normal. Consequently, any creatinine or TSH level that would be considered normal outside of pregnancy often signifies pathology, demanding immediate investigation. You must know the expected ranges for this turbocharged state.
All right, now that we've mapped the expected dashboard readings for the maternal highway, let's talk about the genuine, high-priority warning lights, the acute presentations that demand an immediate stop and a full investigation.
Yes. When do we stop reassuring the patient and start investigating seriously?
Exactly.
We can start with complaints that intersect with the number 1 and number 2 causes of maternal death: breathlessness and chest pain.
Okay, and almost every woman will complain of some degree of breathlessness during pregnancy.
It will. And we understand this is usually physiological. It's mediated by progesterone, stimulating the respiratory center, which leads to an increased minute ventilation.
So you need to know what normal looks like.
Correct. It's important to recognize the features of this physiological breathlessness. It is common, it's usually of gradual onset, and it's present both at rest and during exercise. If the patient has a normal examination and normal vital signs, this type of breathlessness requires no investigation. It's a normal dashboard light.
But if the onset is sudden, if it's severe, or if it's accompanied by chest pain, that immediately raises the specter of pulmonary embolism, a PE, which is a major catastrophic risk.
Absolutely. And this is where your clinical reasoning has to deviate sharply from the non-pregnant protocols. Which brings us to a critical diagnostics anchor, the use of D-dimer.
For a general patient, a negative D-dimer basically rules out a PE.
It does. But in pregnancy, D-dimer is completely useless.
Tell us the mechanism there. Why does the D-dimer naturally go up?
Well, D-dimer is a product of fibrin breakdown. Because the placenta is a massive site of fibrin production and turnover throughout the entire pregnancy, D-dimer levels naturally increase progressively from the first trimester onwards.
You can't rely on it.
You simply cannot rely on a normal D-dimer to exclude PE, because the normal pregnant D-dimer range is already significantly elevated. It's meaningless.
So we have to jump straight to imaging, and that imaging protocol is carefully stratified based on radiation risk, right?
It is. It's a detailed risk-benefit analysis. You're balancing radiation to the mother's chest, her breast, her thyroid against radiation to the fetus. The first-line investigation in a suspected PE depends on an initial chest X-ray.
Okay, so what if the chest X-ray is normal?
If the CXR is normal, you perform a VQ scan, a ventilation perfusion scan. This involves less ionizing radiation than a CTPA, so it's the preferred choice when the lungs appear clear on the X-ray. It minimizes maternal radiation exposure to the breast tissue.
And if the chest X-ray shows an abnormality, like a pulmonary infiltrate or an effusion,
Then you move to a CTPA, a computed tomographic pulmonary angiography. This is because the underlying lung pathology might interfere with the VQ scan's accuracy, and the CTPA is just superior for visualizing the pulmonary vasculature directly. It will give you a definitive diagnosis of a PE or an alternative lung pathology.
Okay, let's discuss chest pain itself. If a patient reports acute chest pain, what's the level of concern?
The clinical message is singular. Chest pain is not normal during pregnancy, full stop.
Yeah.
It warrants immediate, aggressive investigation.
Okay.
Pregnancy is an independent risk factor for rare but devastating cardiovascular events. The incidence of acute coronary syndrome, ACS, and critically aortic dissection is increased. If you suspect either, you must investigate and treat that patient acutely, exactly as you would a non-pregnant woman. You cannot delay life-saving treatment waiting for an obstetrics consult. It is an acute medical emergency for the mother.
Let's move to the syndrome that really defines maternal medicine, preeclampsia and eclampsia. This starts with a classic combination of 3 findings.
The preeclampsia triad anchor is simple but crucial. Hypertension, so that's a BP of 140 over 90 or higher, measured twice, 4 hours apart, usually after 20 weeks gestation edema and proteinuria.
And we have to differentiate normal swelling from pathological swelling.
Absolutely. Mild ankle edema is extremely common and physiological. However, significant rapid onset edema, particularly if it involves the face, the hands, or the sacrum, should immediately raise suspicion.
And if that preeclampsia progresses, the ultimate emergency is eclampsia, the seizures.
Eclampsia is defined as generalized tonic-clonic seizures that occur in a woman who has preeclampsia. The critical time anchor here is that this usually happens after 20 weeks gestation, though it can occur post-delivery.
And we have to distinguish it from other seizures.
You do. You have to distinguish it from seizures due to pre-existing epilepsy or from seizures that are secondary to acute electrolyte abnormalities like hyponatremia or hypoglycemia, which can happen with severe vomiting and hyperemesis gravidarum.
And the emergency management hinges entirely on this differential diagnosis. eclampsia versus status epilepticus from other causes, the treatment drug is fundamentally different.
This is a high-stakes clinical decision. For seizures that are due to eclampsia, the treatment is very specific. 5E magnesium sulfate. The protocol is a 4-gram loading dose followed by a 1 gram per hour infusion for 24 hours.
And how does it work?
Magnesium sulfate acts primarily as an anticonvulsant by stabilizing the vascular endothelium and potentially acting as a cerebral vasodilator. And its administration is followed by planning the delivery of the baby because delivery is the ultimate cure.
What if we determine the seizure is not eclampsia? Maybe it's a known epileptic patient who missed her medication.
If it is status epilepticus without preeclampsia, so that means before 20 weeks, or without the associated hypertension and proteinuria, the management is standard neurology protocol. You immediately administer the V-benzodiazepines, like lorazepam, to stop the seizure. This directly addresses the neuronal electrical disorder. You have to get the diagnosis right based on the timeline and presentation before you choose your drug.
Okay, moving to the terrifying risk of circulatory collapse and hemorrhage. The physiological adaptations, actually, they hide the danger here.
They do. That 40% increased blood volume provides a massive physiological buffer, but it's a false safety net.
How so?
Due to this reserve, the classic signs of shock hypotension and tachycardia may be late, pre-terminal findings in a hemorrhage. By the time the patient's blood pressure drops, she has already lost a massive, potentially lethal amount of blood. Clinical vigilance based on external signs of blood loss or monitoring for changes in mentation is absolutely essential.
And what are the main obstetric causes of collapse we have to rule out?
Well, aside from hemorrhage antepartum or postpartum, we have to consider PE and also amniotic fluid embolism, or AFE.
AFE sounds bad.
AFE is a catastrophic, though rare, syndrome. It involves a sudden introduction of amniotic fluid into the maternal circulation. Its features are typically dramatic. Profound, sudden shock and collapse happening during or immediately after delivery, and it's almost invariably accompanied by a severe, sudden coagulopathy.
And the management.
It's purely supportive. Aggressive oxygenation, mechanical ventilation, correcting the profound coagulopathy, and hemodynamic support with vasopressors.
The diagnostic timeline is so critical for eclampsia. Let's just reinforce that concept one more time. Host check-in question. A 27-year-old woman presents to the emergency department with a severe headache and then experiences a generalized tonic-clonic seizure. Her blood pressure is 160/110. She is 13 weeks pregnant. Should your immediate treatment be IV magnesium sulfate? If not, what should be your first line and why? If that 20-week rule isn't immediate in your mind, just take a moment to rewind.
The answer is an emphatic no to magnesium sulfate. Although she has hypertension and a seizure, the 13-week gestation excludes eclampsia. By definition, that is a mid to late pregnancy syndrome happening after 20 weeks. This seizure is status epilepticus from another cause, maybe a hemorrhagic stroke, maybe severe electrolyte imbalance from hyperemesis, and it must be treated immediately with IV benzodiazepines, like lorazepam, to terminate the seizure. The 20-week gestation marker is the anchor that separates the use of these two distinct emergency drugs.
Key takeaway, too. Eclampsia is a late pregnancy emergency after 20 weeks. The hypervolemia of pregnancy means vital signs lag significantly behind actual volume loss and hemorrhage, demanding aggressive, proactive supportive care. And PE diagnosis relies on stratified imaging because D-dimer is useless.
That's it. You've got it.
Let's transition now to managing the ongoing chronic medical challenges, specifically hypertension and diabetes, which we established are major risk factors for maternal death.
Right. Starting with hypertension. First, we have to accurately classify the timing. Pre-existing hypertension is diagnosed before the pregnancy or before 20 weeks gestation.
And gestational hypertension.
That occurs after 20 weeks, but without the associated markers of preeclampsia, so no proteinuria or other organ dysfunction.
The moment a patient with pre-existing hypertension becomes pregnant, our pharmacy list changes dramatically. Which standard hypertension medications must be stopped immediately?
This is a critical safety anchor, and one you just have to know by heart. ACE inhibitors, angiotensin-converting enzyme inhibitors, must be stopped, either preconception or immediately upon recognition of pregnancy.
Why are they so dangerous?
They are highly fetotoxic, particularly in the second and third trimesters. They can cause severe fetal renal dysfunction, oligohydramnios, which is low amniotic fluid, and persistent pulmonary hypertension in the neonate.
And what about diuretics, which are so commonly used for essential hypertension?
Diuretics should generally be avoided unless they're absolutely required to manage a coexisting severe condition like heart failure.
And the reason for that is?
Well, remember, The pregnant mother needs that 40% volume expansion. Using diuretics reduces her circulating volume, which can cause placental hypoperfusion, reduce blood flow to the placenta, which can starve the fetus.
So we have a restricted toolbox. What are the safe agents for managing hypertension in pregnancy?
We rely on a select group of vasodilators and centrally acting agents. The treatment is managed with labetalol, which is a combined alpha and beta blocker, nifedipine, a calcium channel blocker, and methyldopa, which is a centrally acting alpha agonist. That last one was historically the standard first-line agent.
And the goal is to prevent progression.
The goal is active blood pressure management to prevent stroke and reduce the risk of progressing to severe preeclampsia.
Speaking of progression, the source material gives a clear list of who is at the highest risk for preeclampsia. This should guide our surveillance protocols.
The risk factors listed are expansive and crucial for risk stratification. They include a prior history of preeclampsia, multiple pregnancy like twins or triplets, a first pregnancy, high body mass index, and increased maternal age.
And the pre-existing conditions.
Critically, yes. We go back to the top 3 causes of death. Pre-existing conditions like chronic kidney disease, established hypertension, established diabetes mellitus, and autoimmune diseases like SLE all exponentially increase the risk.
This just emphasizes why preconception optimization of these chronic diseases is so vital. Okay, let's move to diabetes mellitus, where the management bar is set impossibly high.
It really is. For a woman with established diabetes, either type 1 or 2, the mandate is clear. Meticulous glucose control is paramount. The risks associated with poor control are front-loaded into the first 6 to 8 weeks of pregnancy, the time of organogenesis.
And what is the quantitative measure of poor control that we're trying to avoid?
The risk is quantified by the HbA1c level. Poor control, defined as an HbA1c greater than 97 mmol, which translates roughly to an average blood glucose of 11% or higher, carries a truly devastating risk of over 20% for severe fetal malformations.
20%?
20%. And these are not minor defects. We're talking severe cardiac anomalies, renal and skeletal malformations, and the highly specific caudal regression syndrome, which is a severe, rare defect in the development of the lower spine.
The sheer magnitude of that 20% risk just underscores why preconception care is non-negotiable, and that care includes high-dose folic acid.
Absolutely essential. All women with established diabetes must start a high dose of folic acid 5 milligrams daily before conception. That's 10 times the standard dose of 400 micrograms given to low-risk women. It's necessary to maximally reduce the risk of neural tube defects.
Then the risk of DKA, diabetic ketoacidosis, is heightened too. Why is pregnancy such a DKA amplifier?
Pregnancy is inherently ketogenic due to hormonal changes, so the threshold for developing DKA is actually lower. And DKA in pregnancy is an absolute disaster. It's associated with a frighteningly high fetal mortality rate, ranging from 10% to 35%. The acidosis and maternal hypoxemia cause significant uterine vasoconstriction, which drastically reduces blood flow to the fetus, leading to distress and death. Prompt recognition and aggressive management of DKA, even mild cases, is critical.
How does the diagnosis of gestational diabetes, which arises during pregnancy, differ from established diabetes?
The diagnostic thresholds are significantly lower than those for non-gestational diabetes because we're aiming to protect the fetus from even moderate hyperglycemia. GD is diagnosed, for example, with a fasting plasma glucose of merely 5.1 millimol or higher.
And there's a caveat with HbA1c.
There is. HbA1c measurement is unreliable in early pregnancy and for 3 months postpartum. This is due to the physiological increase in red cell turnover that occurs during and after pregnancy.
If diet and lifestyle intervention fail for GD, what is the standard pharmacological pathway?
First-line pharmacological treatment is either metformin, insulin, or glibenclamide. And the key point is why glibenclamide is the preferred sulfonylurea.
And why is that?
It's an older drug, but its molecular structure means it does not cross the placenta significantly. This is critical because if the drug crosses, it stimulates the fetal pancreas to secrete insulin, causing fetal hyperinsulinism, hypoglycemia, and macrosomia, which is exactly what we are trying to prevent.
And the long-term implications are crucial for the mother's health.
Yes. Women who experience GD have a very high long-term conversion rate to type 2 diabetes later in life, a 5-year risk between 15% and 50%. Therefore, they require rigorous annual screening using HbA1c testing postpartum and intensive follow-up for lifestyle modification. It acts as a predictor for future metabolic disease.
Key takeaway 3. Hypertension management demands the absolute avoidance of ACE inhibitors due to severe fetal renal toxicity. Diabetes management requires preconception high-dose folic acid and extremely tight control, that HbA1c below 97 millimole, to mitigate the catastrophic 20% risk of fetal malformations.
Let's delve into systems where the immune changes, the hormonal shifts, and the volume overload create specialized high-stakes management challenges. We'll start with inflammatory rheumatic disease.
And we have to reinforce that non-negotiable drug list. But the modern challenge lies in the newer biologic agents used for conditions like Crohn's or rheumatoid arthritis.
That's right. The drug safety anchor is always methotrexate, leflunomide, mycophenolate, and JAK inhibitors must be stopped before conception due to known fetotoxicity.
But TNF-alpha inhibitors, the ones ending in JPAR, are often needed to prevent the underlying disease from flaring. So how do we navigate their use?
Well, TNF-alpha inhibitors are generally considered safe in the first and second trimesters. They're often continued to maintain disease remission because uncontrolled maternal disease can also harm the fetus.
But there's a problem in the third trimester.
There is. Most IgG antibodies are actively transported across the placenta in high concentrations, particularly during the third trimester. This accumulation creates a significant risk of neonatal immunosuppression. So the general guideline is to stop these agents early in the third trimester.
But there is a key exception to this placental transfer rule, right? One that you need to know.
The crucial anchor here is certolizumab pegol. This drug is specifically pegylated, meaning the molecule is modified by attaching polyethylene glycol, or PEG, chains.
Which makes it bigger.
It makes the molecule much larger, which physically inhibits its active transport across the placenta. It is the exception, and it can generally be used safely throughout the third trimester if necessary. However, any exposed neonate should still avoid live vaccines for 6 months post-delivery, regardless of which agent was used.
One of the hardest diagnostic dilemmas in this population is distinguishing an SLE flare from preeclampsia. Both can cause fatigue, kidney issues, high blood pressure.
This distinction relies entirely on a detailed review of laboratory markers. This is the diagnostic anchor. In an SLE flare, especially one involving the kidneys, lupus nephritis, you will see evidence of active autoimmune disease.
What does that look like?
Specifically, you'll see red cells or red cell casts in the urine, and a measurable increase in anti-double-stranded DNA antibody levels, anti-dsDNA. That's the signature marker of active SLE. You might also see low complement levels, C3 and C4, because they're being consumed by the immune reaction.
And what would preeclampsia show instead?
Preeclampsia is a primary vascular or endothelial disorder, not autoimmune. So it typically shows abnormal liver function tests, LFTs, and the anti-dsDNA and complement levels should remain unchanged. The presence of red cell casts in the urine is the most reliable, rapid clinical marker indicating a lupus flare, which requires immunosuppressive treatment. Preeclampsia requires delivery.
Okay, let's move to cardiac disease, where that 40% volume load creates immediate danger. Tell us about the structural rule governing valve pathology.
The rule is simple and life-saving. The rule of stenosis. Regurgitant lesions, leaky valves, are tolerated better by the high-volume, hyperdynamic circulation of pregnancy than stenotic lesions are.
Narrowed valves.
Right. Stenosis means the heart has to pump against a rigid obstruction.
And why is mitral stenosis particularly dangerous?
Mitral stenosis, especially when the valve area is less than 1.5 centimeters herd, is extremely high risk. The high heart rate, which is normal in pregnancy, drastically reduces the diastolic filling time. That's the window when the left atrium can empty into the ventricle.
So the blood backs up.
If the valve is already narrowed, the blood backs up rapidly into the lungs, risking flash pulmonary edema, which can be fatal. Management involves aggressive rate control using beta blockers, anticoagulation with LMWH due to the blood stasis, and diuretics like furosemide to manage the volume overload.
An aortic dissection, a true catastrophe, is an independent risk in pregnancy.
It has to be considered in any pregnant patient with acute, severe chest pain. Pregnancy is a risk factor because of changes in the aortic wall structure and the hemodynamic stress of labor. The majority of dissections in pregnancy are type A, involving the ascending aorta.
And the protocol is intense.
Very. Immediate control of hypertension to stop the tear from propagating, followed by an urgent cesarean section for delivery, to stabilize the patient and remove the uterine hypovolemia, and then emergency cardiothoracic surgery.
Let's address the persistent problem of anticoagulation for women with mechanical heart valves. We can't just stop it, but warfarin is dangerous early on.
It is. Warfarin carries the risk of warfarin embryopathy, severe fetal malformations, if it's used during that critical period of organogenesis. Therefore, for women with mechanical valves, warfarin must be substituted with LMWH and aspirin throughout the first trimester, weeks 6 to 12.
Can it be used later?
Warfarin can sometimes be reintroduced later in pregnancy due to the risk of valve thrombosis in high-risk patients, but that first trimester avoidance is mandatory.
Now for renal and liver emergencies. Let's return to acute kidney injury, AKI, in the context of preeclampsia. You mentioned a common pitfall regarding fluids.
Yes, this is a classic example of when standard AKI dogma fails. Patients with AKI secondary to preeclampsia are highly susceptible to developing pulmonary edema. This is largely due to the systemic capillary leak syndrome that's inherent in preeclampsia.
So giving them fluids is dangerous.
The usual practice of aggressively administering fluids to flush the kidneys is dangerous. Intravenous fluid is rarely indicated for a euvolemic patient with AKI secondary to preeclampsia.
So if we don't push fluids, what is the best management strategy for this type of AKI?
The most appropriate management is often a conservative one, advising the patient to drink to thirst and closely monitoring their fluid balance, their inputs and outputs. Spontaneous diuresis and resolution of the AKI are the expected outcomes once the underlying preeclampsia resolves, which is typically after delivery. The principle is do no harm by overloading an already leaky circulatory system.
And finally, the two major liver pathologies: acute fatty liver of pregnancy, AFLP, and obstetric cholestasis, OC.
AFLP is a rare but catastrophic emergency, usually presenting in the third trimester. It's a disorder of microvesicular fatty infiltration of the liver cells, often leading to acute liver failure. The diagnosis is clinical.
What are the symptoms?
The presenting symptoms include intractable vomiting, abdominal pain, jaundice, polydipsia, polyuria, and specific labs like low blood glucose, elevated LFTs, urate, and creatinine. The management is supportive care and critically immediate delivery of the fetus, regardless of gestational age. Delivery is the only definitive treatment.
And obstetric cholestasis, OC, which is more common and less acutely life-threatening for the mother, but still carries fetal risk.
Right. OC presents with severe, often debilitating pruritus or itching, typically localized to the palms and soles of the feet, usually starting in the third trimester. The diagnosis is based on elevated serum bile acid levels and abnormal LFT.
And the treatment?
Treatment for the maternal symptoms is ursodeoxycholic acid, or UDCA, which helps improve liver function and reduce the itching. The key clinical distinction is that UDCA does not reliably reduce the risk of adverse fetal outcomes, like stillbirth. That risk significantly increases when bile acid levels exceed 100 mRel, which often mandates an early induction of labor.
Key takeaway 4. Stenotic heart lesions are high risk due to the rate-dependent nature of heart filling during hypervolemia. When differentiating an SLE flare from preeclampsia, look for active autoimmune markers like anti-dsDNA and red cell casts in the urine. And in AKI secondary to preeclampsia, avoid Vita fluid administration to prevent catastrophic pulmonary edema.
Perfect.
We return now to the second leading cause of maternal death, venous thromboembolism, VTE. We established the risk is 4 to 5 times higher in pregnancy, and LNWH is the safe treatment. The core problem, however, remains diagnosis, where standard non-pregnant protocols completely fail.
They completely fail. And this requires us to discard our standard time-saving heuristics. The DVT investigation anchor is crucial here. First, D-dimer is not useful for excluding DVT, just as it's not useful for excluding a PE.
We've covered that. And the Wells score.
Second, the Wells score, which is the standard clinical decision rule used worldwide for assessing DVT risk, is not validated and should not be used in pregnancy.
Why not?
Because the symptoms of pregnancy-like leg swelling overlap too much with the features used in the scoring system. It just doesn't work.
So we go straight to objective imaging if suspicion is raised.
Doppler ultrasound is the mandated first line of investigation. However, even a high-quality ultrasound can miss a developing DVT. Therefore, the protocol emphasizes follow-up.
What does that mean in practice?
If your initial scan is negative but your clinical suspicion remains high, maybe the patient has severe risk factors or the pain is classic, the protocol is to repeat the Doppler scan on day 3 or day 7 to catch a clot that was small or just developing at the time of the initial scan.
Next to VTE, we have thrombocytopenia low platelets, which demands a differential that ranges from benign to truly catastrophic.
It does. The most common cause is the benign gestational thrombocytopenia, which usually occurs in the late second or third trimester. Platelet counts typically drop, but they remain above 70-80 by 1080 till L. It resolves spontaneously post-delivery and requires no specific intervention.
And what are the catastrophic causes that demand immediate action?
The 3 main pathological causes are HELLP syndrome hemolysis, elevated liver enzymes, low platelets, which is part of the severe preeclampsia spectrum, acute sepsis, and thrombotic thrombocytopenic purpura, or TTP. TTP is a severe rare microangiopathy requiring specific, nuanced management.
How is TTP specifically managed, and what is the critical drug avoidance rule?
TTP is characterized by severe microvascular clotting due to a deficiency of the ADAMTS13 enzyme. Management involves urgent plasma exchange, fresh frozen plasma, and often immunosuppression. The critical clinical anchor is that platelet transfusion must be avoided in TTP unless there is life-threatening hemorrhage.
Why avoid platelets?
Giving platelets can actually fuel the ongoing microthrombi formation and paradoxically worsen the condition, accelerating neurological or renal injury. You're adding fuel to the fire.
Finally, the neurological drug review for women with epilepsy, which circles us right back to preconception planning. We have to discuss sodium valproate again.
We must. We have to reinforce the profound danger of sodium valproate. This is not a theoretical risk. It is associated with the highest teratogenicity of any anti-epileptic drug. It carries an approximate 10% risk of major physical birth defects, like neural tube defects.
And that's not all.
And an extremely high 40% risk of persistent neurodevelopmental disorders. This includes things like reduced IQ and autism spectrum disorders in the exposed child.
40%. That is a risk that necessitates zero tolerance for this drug in any woman of childbearing potential if alternatives exist.
Absolutely. The preconception principle is non-negotiable here. Women must be transitioned to safer alternatives. The safest options are generally considered to be lamotrigine and levetiracetam, followed by carbamazepine. The goal is always monotherapy, the minimum number of drugs at the lowest effective dose required to maintain full seizure control.
Because seizure control is also vital.
It is. A maternal seizure also risks fetal hypoxia.
And for migraine management, which is a common complaint.
Migraines often paradoxically improve during pregnancy, especially for sufferers of menstrual migraines. Management starts with simple analgesia like paracetamol, often combined with antiemetics.
And if that fails?
If simple analgesia fails, triptans, the sumatriptan, can be used. Although data on triptans during pregnancy is limited compared to older drugs, the current safety profile is generally reassuring. This means the benefit of controlling a severe migraine flare outweighs the theoretical risk, provided simple measures have failed.
Key takeaway 5. VTE protocols are unique. Disregard D-dimer and the Wells score. Imaging must be prioritized and potentially repeated. The critical danger of sodium valproate, that 40% risk of neurodevelopmental harm, means preconception switching for epilepsy is essential. And TTP, unlike most causes of low platelets, requires plasma exchange, not platelet transfusion.
You've summarized it perfectly.
This has been a crucial deep dive into maternal medicine. We have successfully mapped the new dashboard for the maternal highway of adaptation. Every system shifts dramatically. The hyperdynamic heart with that counterintuitive fall in diastolic pressure.
The low renal thresholds that make a normal creatinine pathological.
The hypercoagulable state hidden by hemodilution. We anchored the critical drug precautions, ACE inhibitors, methotrexate, and especially valproate, and solidified the pathways for rapid recognition of emergencies like eclampsia.
The 20-week anchor.
AFLP with the vomiting, jaundice, low glucose, and VTE with its reliance on imaging.
Maternal medicine demands precision. There is just no room for error when you're managing two patients. You have to be rigorous in adhering to specific drug protocols, knowing why LMWH is safe, while DOACs and first trimester warfarin are contraindicated.
And for those complex differentials,
You have to rely on the specific combination of findings. Hypertension plus proteinuria after 20 weeks is preeclampsia. But if you add red cells, casts, and elevated anti-dsDNA, you've diagnosed an active SLE flare. If you see liver failure and hypoglycemia in the third trimester, you're looking at AFLP, which necessitates immediate delivery. Mastery here is about adapting your standard internal medicine knowledge to this hyperdynamic state.
it truly is about mastering the exceptions and just resetting your baseline expectations.
Absolutely. And as we finish this deep dive, I want to leave you with a provocative thought that builds on the fundamental problem of VTE. We know pregnancy is a profound hypercoagulable state, and VTE remains a leading cause of maternal death, often necessitating pharmacological interventions like LMWH. Considering this physiological truth, what long-term non-pharmacological interventions, perhaps involving diet, exercise, or inflammation management, might be universally prescribed to high-risk women before pregnancy to naturally shift the coagulation cascade equilibrium to a safer baseline, without relying on daily injections during gestation or impacting fetal development?
A physiological solution to a high-stakes mechanical problem.
Exactly. It's a challenge that seeks a fundamental solution.
That's a great thought for our listeners to mull over as they synthesize this complex material. Thank you for joining us for this vital deep dive. We will catch you next time.